I bet one of those people is Jim Cameron. Is Jim Cameron on the line? Oh, okay. Well, I would have lost my bet. Who is on the telephone, please?
This is Jake Ruckman.
Say that again.
Jake Ruckman.
You are. Oh, I've got Jay Crookman. Yes. Sorry, Jay. I did see you. I forgot to write you down. Now, somebody just was number 5, and I didn't catch you. So let's. No, we're good.
That was Jay, I believe.
Oh, that was Jay. Okay.
Yes, I was having some audio, so I was on the GoToMeeting, but I had to dial in, and then the audio kicked in. So.
Okay. So we're good. So who else is on the telephone, please?
Rick, I'm John Appler. I'm on both services, telephone and web. I have a bad web connection.
Okay, we're not doing too well today. We're getting a lot of feedback. If that was you, John Appler, are you on the phone as well as on the web?
Yeah, I just muted my phone mic.
Okay.
That sounds better.
That sounds much better. Yeah, okay.
Yep.
So you are one of those. And who else is on the telephone? Anyone else who'd like to identify? Okay. So whoever's on the phone and isn't comfortable identifying, that's just fine. Please listen in. You're really welcome. If at any time you want to speak and want to participate, you please do so. If not, listen right along. So, yes. Okay, I'm getting some feedback from somewhere. I don't know, but let's keep moving along here. So I'll just run down, and I see Jake, Dennis Correa, John Appler, Dr. Steve Bornstein, Jay Kruckman, Paul Frieda, who just joined us. Have I missed anybody?
I just joined, Paul Frieda.
Got ya. Okay. No one else. Right. So, since we don't have anybody new yet, let me run down and see who would like to take some time today, and we will go from there. So, Jake, would you like to talk about anything today?
No, I don't have anything, Rick.
Okay.
I haven't been to my doctor lately, so no news.
Okay. When are you going to your doctor next?
And near the end of the month.
Okay.
I had an appointment in September, but I skipped it, or in August, and I skipped it because I was sick.
Okay. Okay. Dennis Correa, would you?
Yes, I'll give you a quick update on my visit yesterday to Mayo Clinic.
Excellent. I'm looking forward to hearing about that. John Appler, do you have anything you'd like to talk to us about today?
Well, thanks, Rick. I'm about to start IMRT at UCSF, and if anybody has any advice on making sure I get the right technicians, the right machines, any of that kind of what to do at UCS regarding IMRT, I'd appreciate the advice.
Okay, we can give you the benefit of our wisdom to the extent that we are wise. Dr. Steve, how are you? I'm sorry I've been running around like a blue-ass fly today, so I couldn't get back to you, but we'll talk maybe tomorrow. How are you?
I'm doing well, thank you. Yeah, nothing for me. I'm going to be seeing Larry Fong next week on Wednesday, so maybe something after that. But I just reached my 1-year anniversary on enzalutamide, so that's good, I guess.
Oh, that's terrific. No, that's
Yeah.
really good. Well, maybe you could give us a little update, because I don't know that we've heard from you on here, so it looks like we're going to have a bunch of time. Jay Kruckman, how about you? Are you making progress?
Just I'll give a quick update on possible appointment with Alicia Morgan's.
Excellent. And it would give me the opportunity to give some really positive feedback on Alicia Morgan's too. Paul Frieda, how about for you?
Nothing for me today.
Okay. And somebody else joined us on the telephone whilst we were going around. Who was that?
This is Sylvester Mann.
Hello, Sylvester Mann. It was lovely to see you over the weekend.
It was a pleasure. And hello, everybody. I apologize for being late.
Anything you'd
Hi,
like?
Sylvester.
Anything you'd like to talk about tonight, Sylvester?
Not at this time.
Okay. So have I checked in with everybody? Have I missed anybody? Okay. So let's kick off with Dennis Correa, who has recently returned to his old doctor. Dennis, just fill the guys in briefly on your situation, please.
Okay.
And tell
All
us
right.
how you did when you went back to see Dr. Parminder Singh.
Yes, it was a great visit.
Good.
I finally got a little more satisfaction and confidence in the doctor that I'm seeing now, Dr. Singh. He is at the new Mayo Clinic Cancer Center in Phoenix, and I was very impressed. Very, very nice facility, latest and greatest of everything. As far as my situation is concerned, I went in there and told them what was going on. I had a recent rise in my PSA, at a faster rate than what it had been going up for my previous 3-month periodic testings. And so first thing he did is set me up with a lab appointment that day. Got my PSA done. They use the ultra-sensitive PSA test.
Mm-hmm.
And so I got that done, and my PSA came back at 2.1 versus what I had my most recent one a few weeks ago at U of A Cancer Center, where I got about 1.8. So this could be a difference in labs, or it could be a real addition or an error from the U of A lab testing or what have you. We don't really know that, but it does look like it's nevertheless going up significantly. So with that information, he's scheduled me for some further testing to determine exactly where my cancer is at this point. And what we've got scheduled is for the 28th and 29th of this month. I'm going back for a new type of a PET scan, which they have there, using this flucyclovine type PET scan. Supposedly it's better than the 11C choline PET scan.
Right. It's called Axumin, and
yes. That's it.
I ate a chicken salad lunch courtesy of them on Saturday.
Oh, good.
And so did Sylvester.
How was it?
I saw Sylvester eating that lunch too. So you can ask Sylvester questions about Axumin. We can check if he was paying attention.
I was too busy eating.
Oh, okay.
So what he wants to do with that, we'll see what my progression is looking like, and then decide what the specific treatments would be. But he did confirm everything I've read and things we've talked about from the standpoint of how much the treatment schedules and technology, diagnostic, everything has changed since, a little over a year ago.
Mm-hmm.
And that's changing. It's changing rapidly, lots of things. So
Mm-hmm.
I just had a great confidence level that he was pretty up and running with the latest and the greatest developments and willing to put those into use. He did talk about, I think it was proton beam radiation, briefly, of my prostate.
Mm-hmm.
He says, but we don't know yet. We're gonna see what everything looks like. Gonna do that scan. I guess it goes like from the lower part of your legs up, or the middle of the thighs, I guess, up through the skull.
Correct.
And but one of the things he said that was kind of new to me, I think he was talking about. He said they're finding that when you get a progression, such as mine, where I'm already metastatic and my initial treatments have failed by indication of a rising PSA, that the first place the cancer starts to come from is the prostate again. So thereby he's thinking that if that is the fact, and I think you mentioned this, Rick, about going back and radiating the prostate, that might be an option. And he also talked about the abiraterone and enzalutamide stuff. So we will see at that time. I go up in the morning, get there. I have to do fasting and so forth, and prior to this test, and then 90 minutes or whatever of the test itself, and then they'll have have it read and have all the results that evening. And I will see Dr. Singh in the morning for a review of that and his suggested further treatments.
Did he discuss with you that another alternative might be more chemotherapy or not?
No, he did not.
Okay.
Yeah, I know that's a probable option with a carboxytaxel.
Yep.
But he didn't specifically mention that.
Okay. So I just want to make a couple of comments, and I'll throw it open. It's really interesting how many times I'm hearing this concept of debulking the primary, which of course Dr. Steve will comment on because he's done that with SBRT. I just wrote a note to Ken Anderson in Phoenix, who is being seen by Paul Korn in Houston at MD Anderson, and who is also getting some local treatment. And he's getting set up for some sort of debulking of the primary, although it's not exactly clear to me. He's talking about IMRT and 25 sessions, and I just wrote back to him and said, I don't see why you would want to do that when you could do SBRT and do it in 5 sessions. And I would probably make the same comment to you. I don't think proton beam is available in a targeted fashion. And if it were me doing radiation and it was only to my prostate, and I could do it in 4 or 5 sessions with something like a CyberKnife, or CyberKnife, of course, is a trade name, but stereotactic body radiation therapy, SBRT, I'd probably be looking to see if I could do that, especially for somebody like yourself, because you don't want to be schlepping back up and down from Phoenix for 20 successive sessions. So
yeah, you might be right, Rick. You may have. I know they also have the stereotactic body radiation there, radiotherapy there.
okay.
They offer all sorts of radiotherapy.
Okay. Oh, and by the way,
So,
I do have a Moyad book for you, Mr. Correa. It may cost you lunch again, though.
Okay, I think we can do that.
So yes, I mean, it's just interesting. I mean, a year ago, 2 years ago for sure, no one talked about debulking with radiation, and a couple of people like Mayo and Memorial Sloan Kettering were doing some surgical debulking with stage 4 disease. And now, just hearing it from MD Anderson, we're hearing radiation from Mayo. Mayo never liked radiation. Mayo always wanted to do surgery before they do radiation. So it's just interesting how things are changing. How it sounds like you and your wife feel a lot more happier and easy being back with Dr. Parminder Singh versus the experience with Dr. Arman at U of A.
Absolutely. The other issue when he was talking about, how you're feeling and so forth, and I mentioned to him about my hips and legs and so forth, and having, some occasional pain and so forth. He right away went to, I think that might be your osteoarthritis.
Mm-hmm.
Oh, he quickly pulled up my old scans that he had, and he scanned down to the joint, the ball and the socket on my hips.
Mm-hmm.
And in both of them, you could see there was no space left between the ball and the joint. And he says, no, this is arthritis, clear and simple right here. That's why you're getting your pain. So he mentioned right away about, I might want to contact the joint replacement surgeon. To me, that's second. I will deal with this until we get, a better idea. I've read some things, I believe, about once you put those joints in, it kind of limits you on some possible treatment therapy. I'm not sure, but I seem to recall reading something like that.
Yeah,
it may restrict you from some types of treatments.
Well, maybe Steve knows more about that, but I have heard that certain therapies. But let me just say that maybe we can get a deal, Dennis. 2 for the price of 1. What do you think? Maybe you and me will go to the surgeon together. We'll see if we can get. What do you think? Cut price? You
got the same issue, huh?
I got to get a new hip probably by the end of the year. I should get 2 new hips, but I've only got one that's really bothering me. But I need 2.
Yeah.
And unfortunately, the choice in Tucson is not great. But I just discovered a really good option in San Diego. But the choice in Tucson, I'm not going to spend time talking about me and the hips, but the choice in Tucson is not great to have it done anterior. So anyway, look, this is overall, I think what I feel so good about is that we got you out of the grips of a doctor that didn't seem to much care about how he was treating you, back to a guy who really cares about how he's treating you.
Yeah, that was key for me. It was so evident.
Yep, and it's so important. Let me throw it open. Steve, anything to say on hip replacements and treatment, or or debulking, or anything else?
Yeah, I think, if you're having an Axman scan and it looks like your disease hasn't progressed in bone and there is evidence of increased prostate disease, I would agree with Rick that the stereotactic radiation is preferable to IMRT or external beam because of the fewer treatment cycles, and that's just more convenient. So I would push for that. The other thing they'll insist on, of course, is a 3 Tesla MRI, not just the Axman PET CT, which will be extremely accurate in terms of visualizing your prostate, because most MRIs are 1.5 Tesla, so this is exponentially more powerful. And so the 3 TET, or they call it multi-parametric MRI, will visualize where to treat you, and that's how they guide the SBRT. the stereotactic radiation, they superimpose that over your CT that's done concurrently with the treatment. So I think that, Rick makes a good point. If they're going to do it, of course, the question is that the rise in PSA, or is it coming from somewhere else? And, if there's other metastases other than bone, liver, lung, or lymph nodes, or wherever, that puts it into a different situation.
Mm-hmm. Is this called the 3D radiotherapy? The MRI, is that what you're?
No, it's 3T as in Tesla, MRI.
Oh, 3T, okay.
As in Tesla. That's the size of the magnet that's actually used. And so it's used in the stereotactic radiation of the prostate to visualize and identify very exactly the areas of the prostate that you're treating and the geography of the prostate. So that would be another test, which is fine because there's no radiation exposure. It's just a matter of getting it approved insurance-wise, because as are all things, it's not cheap,
Mm-hmm.
But that would be my thoughts. As far as the doing radiation to the prostate, once you have advanced disease, that's what I did, a year and a half ago, let's call it, a year and several months ago. The one thing I must say is that my peripheral neuropathy did increase. So, everything you do has a price. It's not like things are free. And so side effects, there are side effects. So you don't want to, it's not nearly the side effects of a radical prostatectomy, but nothing is without side effects. So I think you have to gauge very carefully the benefits versus the risks.
Steve, do
Sure.
you think that the neuropathy was attributable to the SBRT more than, say, just delayed effects from the chemotherapy?
You toss the cards in the air and you take your pick. I have so many reasons to have neuropathy. It could be the chemo. It could be my spinal stenosis and disc disease. It could be, the radiation. It could be idiopathic, where nobody knows. I don't know. All I know is it's gotten more dense since the radiation. But you're absolutely right, Rick. It could be an effect of the Taxotere a year and a half later. Also, I'm sure.
Now, one thing that I heard when I was at PCRI, which I don't think I fully understood before, and I think Dr. Steve can educate all of us on this because he probably will have a much better understanding than I'll ever have, was that the cells that metastasize and finish up in distant places, those cells are not the cells that are likely to spread. The cells that spread come from the stem cells, which come directly from the prostate. And it's the stem cells that are the ones that are aggressive and are moving out. I didn't fully understand that, but this was the gist of what I thought I heard. And if that were the case, it would make a lot of sense because there are more stem cells coming from the prostate than from anywhere else. Did I just talk a bunch of rubbish, Steve, or does that make sense?
Yeah, that's exactly what Dr. Singh was telling me.
Yeah, I don't have any real knowledge on that. I just would have to say that, cells, cancer cells that are more aggressive tend to metastasize. So hence the reason for the Gleason score to begin with. Now that they're circulating tumor cells and circulating free DNA, the propensity of prostate cancer to go to bone is one thing, but then there's other cells that are coming from somewhere that eventually can get more aggressive in other areas. And so I really don't know. Stem cells, it's great to talk about stem cells, but I don't know if anyone has any real scientific knowledge about where the distant metastases are coming from. I'm not sure how you'd study that.
Well, we'll keep pushing away on that one. We'll try Professor Bill on that one next time he's on the call and see if he can help us understand this. issue. But it's interesting that you heard it, Dennis, because the point was made a couple of times by different presenters, and you know, I wasn't, and they really brushed over it. But anyway, is there anybody on the call that would like to say anything to Dennis or ask him any questions about where he's going with his treatment? Okay.
So Dennis, this is Steve, one more question. Have you not been on enzalutamide or abiraterone yet?
I have not. No, I just had the docetaxel and Lupron.
Yeah, you know, just from just my opinion, and take it for what it's worth, I might go with starting one of those either with or without the radiation to the prostate. I would certainly, you know, get some sort of systemic therapy going, because you can't be sure that it's just the prostate. And as your PSA is rising, you might want to start either enzalutamide or abiraterone. And like I said earlier, I've been on enzalutamide a year, tolerating it pretty well, although this heat spell we have here in the Bay Area, I'm just dying here. I got my fan going, and it's you do get a lot of hot flashes and so on, but it's pretty well tolerated, and it is systemic therapy, so it doesn't really care where the cell is. It just cares if the cell is susceptible to that type of hormone therapy.
Yeah, and he did mention those, and he probably even hinted at doing both.
Both together, yeah. That's a very good idea. The more I think about it, read about it, that's what I'm going to do. I'm going to be starting on abiraterone and very low dose prednisone probably pretty soon after I see Larry Fong up at UCSF, because I have a feeling there's a population of cells that will respond to the enzalutamide, and another population that might respond to the abiraterone. And the more things you throw at it, the more cells you're getting. And so the resistance to one or the other may be a factor of having had taken one or the other. So I do think this multi-pharmacy, just like kids with leukemias and childhood leukemias, they throw 5 different drugs at them. I personally think the more you can throw at it within the risks of tolerating it, it's always a good idea.
Yeah, I recall that we had in one of our sessions talking about the liquid biopsy, and I think it was the ARV7 test, the blood test. From that to determine which of the two, the abiraterone or the enzalutamide, would be most preferable for an individual?
Well, the problem is if you're ARV7 positive, you're not going to respond to either of them. So the reason to do the ARV7 is really financial. I mean, if it's not going to cost you to go on either enzalutamide or abiraterone, which are, the sticker price is roughly the same. It's a little over 10 grand right now. I think Jake just saw a bill for 10,300. It's not what he paid, but then he saw the bill. And the abiraterone is right up there in the 9s. So that's the sticker price. Now, depending on your insurance, you're going to be paying anywhere from almost nothing to 20% of that amount. And 20% of 10 grand is a couple of grand. If you run the ARV7 test, which will cost you about $1,000, although the insurance companies are tending to approve it because it's in their best interest, and you find that you're ARV7 positive, meaning that it's highly unlikely you're going to respond to either the enzalutamide or the abiraterone, then by doing that test, you're going to save yourself some money.
Well, there'd be time factor in there too, wouldn't there be?
Yes.
If you were trying to evaluate it, particularly in combination with something else,
Yeah, because it's going, I mean, guys that I know have failed, it's taken them about at least 30 days to figure out they're failing.
Oh, that's all? I thought it may have been months or something.
Some are longer. Some are good for, some are good for a month. They figure it out after a month. Some of them figure it out of 3 to 4 months. Either way, they get very little out of it, and it's not consistent. So you could always say, well, at least I got 4 months out of it. It's a good argument. but it's costing you. So, you know, I know Steve has I wouldn't say a different opinion, but it didn't cost him to go on to the enzalutamide. So he said, it doesn't matter to me to find out if I am or I'm not. And it turned out that he was ARV7 negative. Well, we think, because he's been responding.
Yeah, well, I think you make a good point about the finances. Not just, you know, as a physician, you know, 30-something years in practice, I don't like the thought of cost driving care. You know, I honestly don't like that to be the reason that you don't take some drug. But I think in the real world, it's very valid. And I think, of course, Johns Hopkins is the only place where you can get the ARV7 testing done. It's proprietary, and insurance typically won't pay for it. And then there's a small percentage of men who are ARV7 positive who actually do seem to respond for a while. So if it doesn't cost you too much, and this is the differing view, I'd probably go on it for 2-3 months and see how you do. That's just my own feeling, you know.
Yeah.
So the one thing I want to tell you about that I heard at PCRI is that Genomic Health will be bringing out a commercial ARV7 test in January. We heard about it last year. I think Phil Febbo mentioned it to us when he was on our when he did a plenary for us. If not, he might have told me. But I've been expecting it. They thought they were going to have it out by now. But there was a Genomic Health doc there giving a breakout session on active surveillance. So I just went up and introduced myself to him. And he told me that they're scheduling to launch their ARV7 test in January. And he didn't know what the situation is in terms of whether it's being covered by Medicare and others. My guess is it'll probably be cheaper. And my guess is that if there has to be a whole bunch of demand for this, and probably Genomic Health has been lobbying with the insurance companies to cover it, so that there's demand for it. They got a business model for it. So that's kind of good news. It'll be another alternative.
Bad. I think if the insurance company will not pay for enzalutamide abiraterone because you're ARV7 positive, but they'll pay for the ARV7 testing, that's not a good thing for patients.
Mm-hmm. Isn't there supposed to be a generic out for abiraterone early next year?
Yes. Yeah. What's it called? Yes. You're absolutely right.
Bayer's coming up with another drug, right? Is that what you're talking about?
Yeah, no. There is another formulation of abiraterone coming out. I forget.
Yeah, it's Bayer's product, correct?
No.
What's it called? Yeah, it is. I think Bayer's.
Absolo or something like that. I believe it starts with an A. Epsilon or something like that.
Yeah.
The Bayer product is ODM-201, which is
that's an ODM-201. Yeah.
That's a different drug to the abiraterone. The drug, what we're talking about, is a different formulation in a different size of pill. I didn't really get it, but somehow or other they've been able to separate and create another drug. The other thing is that abiraterone should be going generic as well in and of itself. But there's a slightly different formulation and a different strength that's coming out, and I can't remember the name of it. I'll see if I can Google it and find it. It was mentioned by a couple of the people, but it's not a different product. The ODM-201, which is the Bayer product that they're testing, the hook for that is that they suspect it may work for men who are ARV7 positive. So that's the market they're going after. So, okay. Anyone else? All right. Well, Dennis, it's all good news. we've kicked around a whole bunch of stuff here, so it's been pretty useful discussion for everybody. And you know, I'll be in touch with you next week because we'll be able to get together, and I'll pass on the Moyad book for you.
Yeah, sounds good, Rick. Thank you.
John Appler, hello, aloha. You with us, John? John Appler?
Sorry. Hi, Rick. I couldn't get my mute, but can you hear me okay?
We can hear you just fine, but just bear with me 1 second because I see there's somebody new has called in. Did somebody arrive recently on the telephone?
Yeah, Rick, it's Jim Cameron.
Oh, Jim Cameron. Welcome, welcome. We will come to you in a minute because you have a story to tell. But we'll just finish off with John Appler, and I really would like the guys on this call to hear your story. I think you know, there's a lot to hear, and you haven't been on since since you and I have been talking. So, John Appler, your question is what to expect with IMRT, and are there any shortcuts at UCSF? Is that right?
Yeah, kind of, Rick. I mainly want to, along your vein of being your own advocate, I want to make sure I get the best technicians and the best machines. And yeah, I'm at Zion. Should I be down at Mission Bay instead? Are the machines newer there? All those kind of optimizing your experience. I'm assuming that the technicians you get to administer the radiation are pretty key to determining your side effects, after the fact. So any tips on how to optimize my trip there would be great.
Okay. So, we'll go around and let some other guys chip in, but I would say a couple of things here. First of all, I don't think the skill of the technician is that important because the machine is instructed by a program. So clearly, yes, it's important they line you up right, but we have to give them credit that they have the basic skills that they can get you lined up right. And I don't think I've ever heard of one technician being better than another in terms of that. But once you're lined up and you've got these gold fiduciaries that are implanted in you, the machine, which is the way UCSF does it, the machine triangulates on those gold fiduciaries. So I don't think you have to worry your head about the technician. And some are good. I think they're all pretty good. I forget the name of my technician at Mount Zion. She was a lady. She was very, very nice. I forget her name. I cannot tell you whether there is a difference in equipment between Mount Zion and Mission Bay. It's something you have to call in to Mac's office, and you'd have to ask them, is there a difference? At the same time, what I can say is that if you want to see Mac, he may tell you, if you want to see me, then you got to see me at Zion. And that might mean for you that if you preferred the equipment at Mission Bay, then you're going to have to make your way from Mission Bay up to Mount Zion to see Mac on the days that you're scheduled to see him. Which you can do.
Yeah, no, I have no scheduled appointments with him at all. I only communicate with him via, my chart email. Is it customary to have a meeting with him before you start IMRT and go over the plan and that kind of thing?
Well, when you go there next week, you will probably, and when you're all scheduled, part of what is there is you will most likely speak to him at the beginning, and then usually you speak to your doc once a week. I think it's on a Thursday with Mac. You meet with him.
Okay, thank you. I'll get that set up.
So they probably do it. I think what I would suggest is call whoever your liaison, your point person is, and ask them, what dates they have you scheduled with Mac.
Okay, will do. Appreciate that.
Okay.
I'll also be meeting with my brachytherapy person, a doctor for the first time, Dr. Sue, and I'm just curious if you have established a reputation that he has, given the number of people who may have used him in our group here.
I'm sorry, I didn't hear what his what therapy did you say?
He's going to be doing my brachytherapy in November.
Brachytherapy. Okay. I don't. Oh, Dr. Shu. Yeah, Joe Shu's Shu. He pronounced it Shu. I know it's spelled HSU, but it's Joe Shu. Yeah.
Yes, correct.
I mean, I don't know Joe Shu personally. I know a number of people that have seen him. Most everybody likes him. I think he's pretty vanilla. He's the guy that does the brachy. So you're doing high dose brachytherapy then?
I don't know if it's high dose or low dose, but I'm definitely doing brachytherapy.
Okay, well, if you're seeing Joe Shu, it sounds to me like it's high dose brachytherapy because he's the guy that does the high dose brachytherapy.
Okay, thank you.
As far as the equipment is concerned, again, you're just going to have to ask Mac or Joe Shu if there's a difference in equipment. I mean, one would think that the most recent and most modern equipment is at Mission Bay, but it may be that they've made all the most recent changes to and innovations and gizmos to the machines that were in Mount Zion. But the machines must have been in Mount Zion longer than they've been in Mission Bay, but I don't know how often they replaced them. So can't tell you.
Yep, good. Question I'll ask.
Right. I personally don't think it makes a difference. I think that.
Okay, good.
And the reason I say that is because I trust my docs. And if I'm seeing Mac's going to give me the best that he can give me. And if he thought that I needed a different machine to the one he's using for me, he'd tell me. I mean, that's
good.
Very personal opinion, but it's how I trust Mac. And I don't think he'd allow me to be radiated by a machine that is not state of the art.
Good to hear. I mean, that's kind of his reputation, is what you're saying, I think, between the lines here, correct?
Exactly. I'm relying on his reputation rather than somebody telling me, oh, this machine's better than that machine.
Yep, very good.
A couple of things I want to say to you about radiation. A lot of guys, usually what they're going to do, well, not usually, what they're going to do is they're going to radiate your whole pelvic girdle initially, and then when that's done, they will subsequently do the brachytherapy, I assume. Is that right? They're going to do the IMRT first and the brachytherapy second. Is that right?
That's correct.
Okay. So, not a lot, but some guys might tend to find after maybe a week and a half that they have issues with their stomach and their bowels. I think I had a few issues, but only for a couple of days. Some guys worse, some guys better, and the guys on the call will tell you their experience. What people do suggest, make an appointment to see Greta whilst you're there, and ask Greta to outline for you your diet during radiation.
Good.
Because
good. My wife's preparing one of her. Yeah, go ahead. I understand.
All the things you're not supposed to eat are the things you should eat during radiation to minimize your stomach and your bowel being upset. So you don't want to have too much fiber. So it's, just during the period of radiation, they'll often suggest eat more white stuff, eat more white bread, eat more white pasta, because it's easier to digest whilst your bowel is being radiated.
Good, thank you. I will do that. I'll get a point with Greta.
So get with Greta and ask her for the radiation. And what she may say is, eat just as you have been. But if you start to have problems, this is what I recommend you do.
Great.
Anybody?
I also.
Yeah.
No, I'll do that. I appreciate that. We'd asked Mac a question about space ore. This is a month or two ago. I first met with him, and he didn't think I needed it. Is there newer opinions out? I saw there was some use in the UK that was further, documented or further encouraged. Is there any new opinions about space ore out there, Rick, that you know of?
I don't. I just don't have the knowledge. I did not attend the space ore sessions, and there was a space ore session. In fact, I think it followed right on from my presentation on Friday. They were in the room after me, and I didn't listen. I honestly don't know. I don't know why Mac doesn't suggest it. For somebody like me who went in with issues, I had IBS going in, I think it might have been quite good, but I don't know. The other thing is that for you in particular, I don't know the value because they're doing pelvic girdle radiation. So they're not going to be as focused on your prostate and your rectum and your anus. Because when it comes to that part of it, you're going to be doing high dose brachytherapy. And what Mac may be saying, and the question to ask Mac is, do I really need it for the pelvic girdle portion? Most guys that get space ore are because they're getting radiation, external beam radiation to their prostate.
Got it, okay.
But I cannot tell you about new studies, and I cannot tell you how necessary space ore is if you're having pelvic girdle as opposed to direct gland radiation.
Yep, appreciate that. I don't mean to monopolize time here, but can I ask you another question?
Go ahead.
Do you normally see some changes in results after the first month in on therapy with blood tests?
Well, you should at some point start to see your PSA decline and start to trend down from the Lupron. How long have you been on Lupron now?
Oh God, it's great. I just now saw the result. It's down to 0.7.
Okay.
Holy cow, that's amazing.
And what did it start at?
It was as high as 5.7. Last month was 3.8. Now it's down at 0.7.
Okay, I'm just making a note there because I can't open it. 5.7, 3.8, 0.7. What you're looking for is for it to get to less than 0.1. And it takes time to get there. How long have you been on the hormone therapy?
Just 1 month.
Okay. So the 3.7 was, the 3.8 was after how long was that after you'd started the hormone therapy, the 3.8?
No, that ironically was before I started it. And just had been doing, extreme diet kind of things up to that point.
So it just
maybe I'll
begin with.
Yeah, maybe the biopsy took away more of the mass or something.
I don't think so, but I mean, yeah, I mean, I don't know why. I mean, you could have had some inflammation. You could have had sex the night before. You could have been riding a bicycle before you did the 5.7. I don't know. But
yeah, no, that was actually the key.
So, I mean, it's good. If you've gone from 3.8 to 0.7 in a month, you're doing great.
Yeah, okay. Yeah, I also see things like, low insulin levels, high RBC levels. Are those things normal to see at this stage in therapy?
Low, what did you say, low insulin levels?
Yes.
And high what?
Low, RBC, red blood cell counts.
No, I mean, that's not from the hormone therapy. It usually takes quite a bit longer. Steve, can I refer to you?
I'm sorry, Rick, did you talk to me?
Yeah, can I defer to you on John Appler's asking about after a month on hormone therapy, he's seeing low insulin levels and low red blood count, and I'm saying, well, it's a little early for low red blood count. Can I defer to you on that?
What's the blood count, John?
It's just slightly under the range. It's 4.28.
That's the total red cells. What's the hemoglobin?
Is 14.4.
Oh, that's fine. That's normal.
Great to hear. Thanks for that, Dr. Steve. Appreciate it.
Yeah. Anything over 12 is actually pretty damn good.
Good to hear. Good to hear. There is a very high CRP score, unfortunately. Is that something you normally see too, or is that abnormal?
TRP, what is that?
CRP-HF.
Oh, CRP.
Yes.
Yeah, CRP. Yeah, it goes along with chronic inflammation. It's C-reactive protein, as it's called. It's just a protein found in the blood with any kind of cancer, tuberculosis, hepatitis, anything that causes chronic inflammation. So that's kind of non-specific, doesn't mean too much.
Good. That's great to hear.
So
thank you.
Some kind person on here has done the research, and the name of that alternative drug is Yonsa. Who was that? Was that you, Jake? Thank you.
Yes, that was me.
Yeah, Yonsa, that was it. I knew it was a funny name. And I really don't understand it, but it's a slightly different formulation. You take it with a slightly different type of steroid. All I know is it's basically given them the opportunity to start marketing an abiraterone type compound just a little bit before it becomes generic. So I don't think it's very different, and it's going to be sold in different sizes, in different dosages to the current one. So
according to Mike Scott, Rick, Yonsa is abiraterone acetate, but it's an improved ultra micro size formulation. Whatever that means.
Exactly.
Different absorption characteristics. I don't see where it says ARV7. It's sensitive to people with ARV7 mutations. So I'm not sure.
That's a different drug, Steve.
Yonsa, I see. That's the Bayer drug.
Yonsa is a different drug to Bayer's ODM 201.
Oh, we're talking about the Bayer drug is the one that might be effective for ARV7 folks.
Correct.
I see. Okay. Yeah. This, just to give you a little background, when they do this, a little different formulation, it typically has to do with the fact that the patent is running down, so they can continue to charge very high prices.
Okay.
That's the way drug companies do things.
What'd you say the new drug that you're talking about was, Steve?
Oh,
well, Yonsa is the one that that we're talking about here, which is abiraterone. It's a slightly different formulation. In other words, it has different absorption characteristics. It's a sub-micron formulation, but it's the same exact drug. And I'm just pointing out that just the way Big Pharma works is they do this kind of stuff when the patent starts to run down, so they can continue to charge $10,000 a month.
Well, this also says it's 500 milligrams was found to be bioequivalent to 1,000 milligram dose of Zytiga.
Yeah, but bioavailability is, I mean, who gives a crap? If you're taking a pill, you're taking a pill. Who cares what's in it, you know?
Right. No, you mentioned another name.
ODM 201.
ODM 201.
And ODM 201 is the new Bayer drug, which is supposed to address men who are ARV7 positive.
Okay. Thank you.
Okay. I don't know when it's due to come out, but it's well along the way, and you know, you can look at the trials and what have you. I can't remember the names of the trials. So okay, so John, we're going to keep moving along. Is there anybody that wanted to give John any words of advice on IMRT? Okay, so we're going to keep moving along, and I want to accelerate Jim Cameron. Forgive me, Jay Krugman and Steve, but I want to accelerate Jay Cameron because of the unusual aspect of what he's been going through, highly unusual aspect, and it's going to be interesting, educational, and I think good for everybody to listen to Jim's story. And we've still got 55 minutes left, so we will get round to the two of you, but we'll maybe spend about 20 minutes talking about Jim because I think it's worthwhile. So Jim, why don't you go back to maybe the beginning of the year when they first started to notice that there was a growth on your prostate, or give the guys a quick background on where where your disease was, and then what happened when they first started noticing, and what's happened since then. Jim? Well, you're muted. Are you there, Jim? Jim?
Rick?
Yes. Now we can hear you.
You hear me?
We can hear you.
Okay. Well, back around the end of the beginning of March, I was up to Johns Hopkins for my quarterly checkup for my eye cancer and the prostate cancer, and they did a CT scan, and Dr. Carducci said I had a 5 centimeter, I guess it was, growth on my prostate. He didn't think anything of it, and at that time I was on vacation from Trelstar, and I was going to go back on Trelstar that day. He said that should take care of it. So I went back on Trelstar, and then shortly thereafter I started having a lot of incontinence problems. Now my original prostate cancer goes back to 2005, and I hadn't had too many incontinence problems to speak of, but it started to get bad. And next, he told me, well, go see a urologist in Florida, which I did. And he examined he did the scope of my bladder and all, and they knew it was burned. And that's when I started the hyperbaric oxygen treatment, which I did 40 sessions of that, which I completed in May. When I went back to him in June, I asked him, I said, what about the growth on my prostate? He says, I'm not concerned about that. He said, the Trelstar should take care of that. I said, well, can I get another CT scan? And he said, it's not necessary. That kind of really turned me off, and I've been losing, up to that point, I've been losing faith in him a little bit because he fights me on everything. And I said to my wife when we left there, I said, we got to think about maybe changing. Well, anyway, we went back up to New Jersey for a vacation because we were going to clean our house out and put it up for sale, which we did. And consequently, right now our house up there is under contract, so we should be rid of it in another 3 or 4 weeks. Second night I'm up there, I get up and I feel like I got to go to the bathroom, and I can't. This went on for about an hour and a half. Before you know it, I was just about on the floor screaming with pain. My wife called the ambulance. They took me to the hospital. They put a catheter in, and they made arrangements for me to see a urologist that day, who happened to be the urologist who diagnosed my prostate cancer back in 2005. So I did have a relationship with him. Hadn't seen him much in the last few years due to the amount of time I've been spending in Florida. And he said I had a blockage, and he cleared it in the office and damn near killed me because he's ramming this rod down you-know-what to clear the blockage. And it cleared it, and then a week later I got an infection in there, and that was painful, and that cleared up. Then he sent me for another test, and he says, you got 2 blockages, one in your urethra and one in the neck of your bladder. You're going to need to go in the hospital and get an operation to clear it out, which he did. After he did that, my urination was never the same. I had all kinds of problems for the next 6-8 weeks, and I was getting this tremendous burning in my rectum. And I kept saying, this is uncomfortable as hell. He said, oh, it's normal after this procedure. It'll go away. Don't worry about it. And I told him 6 or 7 times. And then it was time for me to come back to Florida because we had our house up for sale, and we're down in Florida full time now. The second day I was here, I went to see my urologist here in Florida, which I had an appointment before I left. And he looked at the thing and he said, let me take a look. And he looked at my bladder and he said, I see something in your bladder I don't like. He said, I want you to meet me tomorrow in the hospital, and we're going to go in and do a biopsy of your bladder. That morning when I'm in the hospital waiting for him, he came in. He said, I thought about your case all last night. And he said, your prostate just doesn't feel right to me. He said, well, I'm in there today. Do you mind if I take a biopsy of the prostate? I said, no, go right ahead. Well, he did that, and they sent both of them off for testing. The bladder came back, no trouble found. The prostate came back as a spindle cell tumor, which they tell me is very, very rare and very, very dangerous. So then they sent me for a CT scan, and it came back. I had 4 spots on my liver. We had that biopsied. Fortunately, that came back as prostate cancer. Okay, down here in Florida, because of the spindle cell in the lung, in the liver, and sent it out to the University of Michigan to have it diagnosed there, and they're sending it up. They have sent it up last week up to Johns Hopkins, up to Epstein's lab last week. The Michigan lab thinks it's all prostate cancer. They don't think it's a spindle cell on my prostate. The people in Florida do, but the Michigan had my specs out there for 12 days. They said they ran all kinds of tests on it, the doctor down here that I'm seeing now, it's been talking to them, and they like I said, they sent it up to John Hopkins. John Hopkins should have had it by last Thursday or Friday, so we're waiting to hear from them. Right now down here in Florida, everything is a disaster after the hurricane. Where we live, we didn't get hit that bad, but everything is still closed. I mean, the hospitals are open, but all the doctors' offices, everything else are buttoned up. There was a lot of trees down in the road, and there was no water for a few days. The water got contaminated, and there's millions and millions of people down here without power. Fortunately, we have power in our house, but majority of people don't. So that's where it's. Okay, wait. And Rick has helped me out quite a bit, and he said he introduced me to Dr. Korn down in Houston, and he's willing to quarterback this with the local medical oncologist down here in Florida. So that's my story. This has been going on now for 6 months. Like I say, I'm in considerable discomfort because I got this tremendous burning in my rectum.
So
when I sit. So
I think a couple of things I just want to bring out, and then we'll discuss. But
I was just going to say, Rick, if I missed anything, I mean, you're as on top of this as I am.
I think the one thing that you missed, and why we always tell you guys you've got to advocate for yourself, is that Carducci. When Jim.
Oh yeah, I forgot about Carducci, which I'm trying to forget about him.
Okay, well, I'll tell that story so you don't have to live it again. How about that?
All right, go ahead, Rick. You know the story.
Rick, unless you get aggravated and tell it.
So, Carducci, when I heard about this, I immediately wrote to a few people, including Larry Fong, who I know very well, who's one of the best GU medoncs in the whole country. And he wrote back and said, look, I don't have a lot of experience with spindle cell. He called it a zebra. But he said, Mike Carducci should be on top of it. Well, the problem was, Mike Carducci, not only was he not on top of it, because he actually sent an email to Jim saying he's not really sure what to do, but probably the way to go is chemotherapy, carboplatin, and docetaxel. But he was also pretty dismissive. I mean, he wasn't supportive. And Jim was really distraught, as I think most of us would be when you get diagnosed with a type of cancer that is very, very hard to treat. And so we reached out to a couple of doctors. We reached out to Dominic Morazi's doctor, Dominic Goresisol's doctor, Dan George, who's at Duke, and we reached out to Paul Korn at MD Anderson, and Paul Korn at MD Anderson responded within an hour, 2 hours.
Yeah, instantly almost.
Unbelievable. And he responded on a first name basis. He signed his name Paul. He said, if there's anything I can do, and I'd be happy to quarterback, and it was almost as if he really was interested to see what he could do to treat a spindle cell cancer. And he suggested something different. He said, look, we've got to see, you've got to get that liver biopsy, which Jim hadn't done at that point in time, and said, we've got to see if that liver biopsy is the same, if it's spindle cell or if it's prostate cancer. He said, because if it's not spindle cell, then it probably means that the spindle cell has not yet metastasized, and that's a good thing because we could go in and do a radical prostatectomy, a salvage radical prostatectomy, and if we can do that and get rid of it, we may then be able to go in and treat the prostate cancer, because once that spindle cell gets too far, we got a big problem. So we decided that we wanted Paul Korn to be the quarterback, but about 3 days later, Dan George also responded. He's the guy that works with the copper and the disulfiram and was Dom's doc, and is also a super guy, and he was very, very supportive too. And we all agreed that the best way to do this is to have a quarterback who's very knowledgeable and a local guy, so that if Jim needs chemotherapy, he doesn't have to go too far. And the other thing we wanted to do, and Paul Korn encouraged us to do, is first of all to send all the biopsies of the liver and the prostate up to Epstein, and secondly to get Foundation Medicine to do genome sequencing of both the prostate, of both the spindle cell or whatever it is, we don't know, and the liver, to see if there's any commonality between the two, and we're in the process of trying to do that. Of course, it's difficult because of Hurricane Irma. But in a nutshell, that's where we're at. It isn't a great diagnosis if it is in fact spindle cell, but we don't really know. The reason why it's such a confusing diagnosis, and we've been told this by a couple of the guys, is that it's probably a secondary radiation cancer. So Jim had radiation back in 2005, and whatever it is that we're seeing on the prostate is a result of whatever radiation was done 10, 12 years ago. And so it's all very confusing. Anyway, I just would like to throw it open. I don't know if Steve's still with us. He had to leave, but if he has any thoughts on this, if he's ever dealt with spindle cell cancer, or if anybody's got any ideas, we're open. We want to do as much as we can for Jim.
Yeah, I'm gonna have to leave in a minute. I got talked into joining a tennis team, and I've got a tennis match at 5. But uterine sarcomas are spindle cell cancers, and dealt with a few of those, and they tend to be very tricky and very unusual. I don't have any specific knowledge about this, but it's fascinating that, in fact, if this is radiation induced, they tell you when they do radiation, 5 to 10 years down the line, there's a higher risk of cancers, and most of us at that point say, well, yeah, I'll deal with that when I get there, but you may have gotten there. I don't know.
Initially, we weren't sure if it was a spindle cell carcinoma or a spindle cell sarcoma, but the biopsies seem to indicate it's spindle cell sarcoma. And the difference between the sarcoma and the carcinoma is that one is within the cell in sort of, and affects the muscle, and one of them is more on the surface of the cell. One's epithelial and the other's non-epithelial. Steve, can you just give us a quick explanation of that?
Yeah, that's exactly right. So a sarcoma is a tumor of the middle cell layer, so to speak, whereas a carcinoma is a tumor of the outer cell, the skin layer, and that would apply not just to skin, but the covering of any organ. So the epidermis of every organ. So they're called mesothelial tumors are called sarcomas, and epithelial tumors are called carcinomas. That applies to whether it's the prostate, the uterus, the ovary, the lungs, whatever, And the preponderance of prostate tumors are adenocarcinomas, so they're gland cell tumors of the epithelium.
So we think, or the local guys seem to think that this tumor on the prostate was a spindle cell sarcoma, but the guys up in Michigan are saying, no, we don't think so, and so we've basically got to wait and see. So I think if it were considered to be prostate cancer, then probably the course of treatment would be more likely some sort of chemotherapy, probably including carboplatin. If the consensus is it is a spindle cell sarcoma, then maybe the first course of action might be surgery, and then followed up with some chemotherapy. And anybody else want to talk about? Steve, you go. We don't want to hold you. Thank you so much for
Thank you all very much. I'll talk to y'all later. Take care, everyone.
Anybody want to talk more and want to ask Jim any questions? Want to discuss this in any way, shape, or form with Jim? Boy, you're a silent lot today.
Are you still on? Are you on a catheter now, Jim?
Am I? No.
Okay.
Urination is somewhat of a problem. I have to wear a diaper all the time because I leak constantly.
And is this since?
Sorry to hear that too.
Is this since you? Is this basically since you had these recent problems and the additional pain, or is this going back a long time, Jim?
This is going back a good year when I started having incontinence problems, and they've just gotten worse over the last year. Before that, I had a little bit of leakage every now and then, and it wasn't too bad. But it started to get about a good year or so now. It's been picking up.
We've had a couple of good discussions on incontinence in the last 2 or 3 weeks. I can't exactly remember, but they're indicated on the website, and perhaps you want to go back and listen to them. Paul Frieda, anything you want to say on any helpful advice for Jim?
I can't think of anything right now. No.
Okay.
Sorry.
Okay. All right. Well,
like I said, the biggest uncomforting problem now is the burning in the rectum, and I'm hoping to get an appointment Friday with the urologist here, who has helped me out, who's helped me quite a bit. So far he seems to be pretty good, and I've only been seeing him for about a year.
This is just a thought, Jim. But have they ruled out hemorrhoids? Internal hemorrhoids?
Yes. In New Jersey, the urologist up there, he just kept poo-pooing it. Nothing to worry about. Nothing. What the guy, the urologist down here, I got here almost 4 weeks ago. That day, he gave me, he examined the whole area down there.
Okay.
Hemorrhoids were definitely ruled out.
Jim, any further discussion or any movement on getting these biopsy samples to Foundation Medicine?
Well, since I talked to you last, Rick, everything closed up down here last Thursday afternoon.
Yeah.
And it hasn't opened up. I can't really get to talk to anybody right now.
Yeah.
I have an appointment next Wednesday, and on the top of my list is the first topic, the Foundation one.
Okay.
And I'm hoping to take my wife, who as you know, always has a lot to say, even though she's going to go on her. She had her ankle surgery. She's gonna go out of the house on her scooter.
Yeah.
She's got one of those kneeling scooters, so it's kind of every time I take her to the doctor, it's a real chore. But she wants to go talk to the oncologist next Wednesday with me.
Okay.
But I made a list of 3 or 4 things, and the Foundation one, I'm going to press that.
Okay.
When we talked about Foundation one last Wednesday when I was there, he was more interested in getting these other things lined up.
Correct. I understand that.
Getting the I had to have the liver biopsy. It took 4 or 5 days to get the people together that they needed to do it.
Right. Okay. Well, thank you very much for sharing that all with us and telling us the story. And I think
I want to tell everybody on the call, the person who's given me the most support and really has helped me out is Rick. He's introduced me to a couple, the Dr. Korn and the doctor up at Duke, and he's helped me with, organizing my thoughts and everything. He's been a tremendous help to me and my wife at this time. Because when this popped up, as you can imagine, this was quite the shock.
That's why we pay him all that money.
Oh yeah, he's worth it, and he's worth every nickel of it.
That's probably about all he gets paid is about a nickel.
Yeah.
Well,
we'll give him we'll double his salary to 2 nickels next year.
There you go.
I say God bless you, Jim, and let's just hope that we can get some, get some things moving and get some good treatment lined up for you in the next month or so.
Well, last weekend we ran into the holiday, which slowed things down, and now we run into this hurricane, and we were lucky as could be here. The hurricane was at 145 miles an hour, 50 miles from my house, and by the time it got to my house, it was down to 100. And I have a pretty sturdy house because we had special windows put in and all the hurricane goodies on. And we rode out the hurricane that night without any we had no damage at all, fortunately, to our house.
You're very lucky.
Yeah, we were. I've been down in Florida here for 17 years, and we've seen some other smaller hurricanes, but when they were talking 140, 150 miles an hour, that's an ungodly amount of wind. And
you're in Tampa?
No, I'm in Venice. I'm about 75 miles south of Tampa and 20 miles south of Sarasota. We're about 80 miles north of Naples, and Naples got wiped off the map down there almost.
Yeah, you were in line for a direct hit for a while.
Yes, we were, and we were hunkering down, figuring, oh, we're in for it. And the way our luck had been going lately, we figured, hey, this will be the kissing blow here. But I went out. I didn't go out yesterday because they told us not to go out, and I didn't. But I had to go out today to pick up some stuff. And even though we only had 100 mile an hour winds, there's trees down all over the place. They finally got all the roads open, but probably 4 out of 5 people don't have power. They might have it now. They didn't have it this morning.
Yeah.
So,
my son's mother and father-in-law live in Venice, and they also escaped any significant damage. I don't know whether they have power or not, to be honest, but thank God.
Where they live in Venice?
No, I don't.
Okay. Venice seemed to do pretty good. And yesterday I went out for a little walk in the neighborhood, and everybody I talked to had power. And this morning when I went out, I had to go to the hardware store to get something. And developments around us were without power, but everybody in our development, which is 1,500 homes in my development, we all had power. Why, I don't know, but we did.
Are your power lines above ground or below ground?
They're buried.
Yeah, well, a lot of times that makes a big difference.
Yeah.
So,
And
Paul Frieda, how was everything okay by you, or?
Yeah, we were very lucky. Originally, it was supposed to go up the East Coast, but then it kept going to the West Coast, so we were quite a bit spared. But I put plywood up on all my windows, and we spent 2 nights in a shelter to be safe, and we came out okay. There's a lot of debris around, and a lot of people don't have power still here in Palm Beach County, but I do. I got lucky, and it was a pretty scary experience.
Yeah, when you're in the house, like we're in the house, and like I say, we got Miami-Dade windows that are supposed to be strong for 175 mile an hour winds, but we had 2 hours, and stuff is pounding off the roof and off the house, flying branches and God knows what.
Wow.
It's well, as you know, you were down here. It's when the hurricane's here, it is darker than dark.
Yeah.
How did you make out in the shelter?
Just fine. We everything was okay, and we did all right. It was it was uncomfortable, sleeping on the floor and not being away from home, and of course all the stress and worry about what's happening in back of your house. But
Right.
but we knew we dodged a huge bullet once it went past the East Coast and started going up the West Coast, because it looked like we were going to get a direct hit for a long time. And
Right.
but,
Up till about Thursday, it looked like you guys were ground zero over there.
That's right. And but from what I understand, Tampa also got missed too. For a while there, Tampa was the bullseye, and apparently it veered away from Tampa a little bit.
Yeah, Tampa, and also I don't understand this because it's in meteorology, but the storm came at the time that the water was going out in the bay.
Yeah.
So they didn't get the surge. In Tampa Bay, they have pictures that all over the place of Tampa Bay being totally empty of water. The entire bay, all the water went out to the ocean.
Amazing.
Yeah, they had photos of it. All you saw was the bottom of the bay.
Wow.
Where the water is usually 16, 18 foot deep, and the whole thing went out.
That's a phenomenon. That's a phenomenon that's similar to what happens before a tsunami. All the water goes out, and then a lot of times it'll come back in a rush. So you're very lucky that it didn't.
That's what they said on the news. They were on there saying, because there was some people walking out and taking pictures of themselves out in the middle of the bay. They said this could turn around in a heartbeat, and you could be up to 18 foot of water in a matter of minutes.
Guys, I'm going to intervene because we still want to talk to Jay Krugman, and it's interesting for us to hear your first-hand experiences. But if we can, I'd like to move on a little bit, if that's okay by you.
Absolutely.
Absolutely. You got more important things to talk about.
No, I wouldn't say that, but we've got other things that win, and we want to make sure we get around everybody. So, unfortunately, we're a really small group tonight. So I saw Peter Kapka came on for a minute or two, and now he's not with us. I don't know if he'll be back or not. Jay, why don't you tell us how you're doing with Alicia Morgan's, and then I can fill you in on my experience with Alicia Morgan's over the last week.
Okay, I don't have a whole lot to say. I did talk to her office late last week, and if you
Hello.
Are you there? We lost you. We just lost you, Jay. Are you there, Jay?
Yes.
We just lost you.
Can you hear me?
We can now. Start again.
Am I there now? Okay. Not a whole lot to talk about. I talked to her office late last week, and if you're going to try and find her right now, you got to be a little patient because they don't know who she is, really. They're very, very helpful, but she's still getting on board there. And I got your email and information about Les. She is starting to take appointments or September 18th, I believe it is.
Correct.
She's only seeing people on Mondays. But that worked okay into my schedule. I will be up there the first week of October. So I have an appointment with her Monday, October 9th. And that's all I really have so far from her.
Well, I think what you've done is set yourself up with a really terrific genitourinary medical oncologist. I mean, I am so impressed the way that she got back to Les Benchy, and then I sent her a note, and she sent me a wonderful personal note back. And, we know she's very smart. I sent around that article that she wrote and her discussion with Chuck Ryan. And, if you can find a doctor who specializes in genitourinary diseases like prostate cancer, who is personable and compassionate and willing to engage you, the patient, on one-on-one, and she's just moving from one institution to another, from Vanderbilt to Northwestern, it's outstanding. And
Well, I hope so too, because she's not in my network, so we'll be a substantial first meeting with her. But I think it'll probably be worth it.
So let's just talk a little bit about that. Your network, would your network allow you to go to any of the NCCN or NCI hospitals?
I don't know that, Rick.
Okay. And are you in a position whereby you can switch your insurance come the end of the year so that you can get into a network that would cover Northwestern?
Probably. Actually, my wife is just taking a job, and I believe she'll have full benefits there. I don't work currently, or haven't worked for several years now, so I'm really on the Obamacare plan. So need to figure that out. I'll know in the next month or so what kind of benefits she will have. Otherwise, look at changing out at the end of the year. Yes.
Have you applied for SSDI, Jay?
No, I have not.
So I'd like to encourage you to look into that. I will try to remember, I will remember, I'm just making a note by your name here, to send you the applications for SSDI. Now, thank God you don't have any evidence of bone metastasis, is that correct?
That's correct.
Right. Neither did I. However, because I was on fairly long-term hormone therapy and because I was fairly compromised and really didn't have the energy to work, I was actually able to get SSDI. And what that allowed me to do was to backdate to to my time of diagnosis. And you have to have 28 months, I think it is, between the time of diagnosis and when you're first eligible for Medicare, when you are approved for if you're approved for SSDI. So if they approved you for SSDI, and since your situation is somewhat similar to mine and you've got recurrent disease, there's a chance that you might get approved for SSDI. Then, once you've been on for 28 months since your disability date, that's not the date that you start getting payments, but it's the date that they consider you first became disabled. You can then apply for Medicare and get covered by Medicare, which is a lot more reasonable, and there are many plans on there that would cover you for a doctor like Dr. Morgan's.
Okay.
So, the bottom line is start looking into SSDI and consider if you want to apply. Now, anybody on this call who has metastasized disease, you have an accelerated approval, and you will get on very quickly. And it's guaranteed. So, I just want to take the chance to mention it. So,
this assumes you're not on Medicare?
Right.
No, I'm not. I'm 57.
Right. I know that. I'm looking. Yes. This assumes you're not on Medicare, that you're under 65, and which is Jay's situation.
Got it.
Okay. Anybody want to talk to Jay say anything to Jay? Jay, I think if you can swing it, you're going to be really happy with with Dr. Morgan. She just seems like a mensch, like a really good person. And you heard, I mean, yeah, you hear the difference between a mensch and a doctor like Carducci, who was so discouraging to Jim Cameron, or Dr. Armands, who sent Dennis Correa's wife into tears because he was such a jerk. And you know, we have to advocate for ourselves, and we have to try and get ourselves to doctors who care about us and who are also smart. And those doctors are few and far between. And one of the things we do through this call is we try and direct you towards the doctors that we know are good. And the reason we know they're good is from experience of other patients who come back and tell us how much they like them. And, you know, sometimes we get good and bad. There's a doctor that comes to mind who a couple of people love, and a couple of other people on this call have not had good experience with. And we'll tell you that too. But we've come across a lot of doctors on this call.
Well, I appreciate that. I also have gone to 3 or 4 us two support group meetings here, and they actually meet at the cancer clinic in the Memphis area here. So I have a resource there to talk to those guys and how they get along with their local people. So. But I do want to go see Dr. Morgan's.
So when you're in those us two groups, if you've got guys who have advanced disease and they're in a general group and not an advanced group, please tell them. We are an us two group, by the way. I don't know if you knew that. I think you did, because you came to us originally through us too. But we are us two certified, and if any of the guys in those groups want to talk to us, we're happy to talk to them. We're happy to talk to them in the low and intermediate group, etc., etc. So we're a resource that you should not hesitate to disseminate.
Thank you.
Okay. So, is there anyone on the call that I have not touched base with who would like to talk? Okay. So maybe what I'll do is just say a few words about PCRI, and then we'll even finish a few minutes early because I've got some plans. I'm very, very fortunate to be taken to the Hollywood Bowl tonight to hear Yo-Yo Ma. So and we've made dinner for a picnic and goodness knows what. I'm in LA still. For me, the highlight. I'll talk to you a little bit about ANCAN after this, but the highlight for me was discovering a doctor that I think will be a terrific resource for people that we talk to on this call, because he's located in Omaha, Nebraska. And we've struggled in the past to find a doctor that is in that area. And to be honest, if Omaha, Nebraska is closer to you, Jay, than Chicago, I don't know if it is, but if it is, I would say that this guy is just as good. Okay. I'm really, really impressed with him. His name is Dr. Luke Nordquist. He trained at Memorial Sloan Kettering, and he has a practice at in Omaha, Nebraska, and he is an independent, but he's doing a lot of research. He works closely with the NCCN and the NCI hospitals. And I don't really consider him in the same category as a Snuffy Myers or even a Mark Schultz. I don't, he doesn't strike me as being somewhat of a cowboy. And unfortunately, whilst I think I think that Mark Schultz is, and his colleagues are a much better practice than Snuffy Myers, who isn't seeing people anymore anyway. They do things that are a little off the wall. And I think that this guy, Luke Nordquist, does things that are a little strange, but he does them after he's tried everything else. And so he is a guy who can be really creative outside the box if he doesn't get the solutions that he wants. And I think he's on top of all the clinical trials. I mean, you know, I'm mentioning trials, and he's saying, well, that isn't exactly what that one does and what this one does. We're talking about we had a couple of good discussions. So I'm going to use him as a segue to tell you that one of the reasons we had such good discussions is because he was absolutely overawed by Jet Teisberg's contraption. He loved Jet Teisberg's contraption. So much so that he came over at one point and asked Jet to do a special one-on-one demonstration for him, which his assistant videoed with her iPhone. And he's talking to us. I've got the email right here on my screen. I just haven't had time to finish it. I was almost done when the call started. But he's talking to us about bringing the contraption to Omaha, Nebraska for an educational exhibition that he's holding on October 1st. This guy loves to use analogies, everyday analogies. So he tries to put things into the simplest terms. He's very committed to making you understand, helping you understand the complexities of our disease and the complexities of how these cells move around. And he does it in everyday simple terms. I heard him in the plenary session, which was to 700 or 800 people. I heard him in a smaller session where there were maybe 40 or 50 of us in a room and people asking questions. And throughout, he was just super impressive. So if any of you, I don't think it applies to anybody except possibly Jay Krukman, if any of you are close to Omaha, Nebraska, and you need a doc, he's a guy that I would not hesitate to refer you to. I'd send you there in a New York minute. Apart from that, I didn't attend a lot of sessions. I wasn't so interested. There were a couple of people I wanted to hear. I listened to Epstein a little bit. I wanted to talk to him one-on-one, and I just couldn't get to him. I listened to John Mulhall, who is a urologist and a sex doctor, for want of a better word, an ED doctor who was just excellent, very impressive. He's at Memorial Sloan Kettering, and one of our guys has already called him, and he's referred them to somebody who's local to them. Who else did I hear? Okay, I'm trying to think. My own presentation, I think, went well. I apologize to any of you who got on the call at 3 o'clock. Two things happened. One, they switched me from 3 o'clock to 1:30, and I only found out 45 minutes before, because it did say 3 o'clock on the conference schedule that was on the web, and then finally they moved me to 1:30, and they didn't tell me. So thank you to Foundation Medicine and David Marshak, who pointed that out to me. The second thing was they told us we could not webcast, so they banned us from webcasting. Unfortunately, our nemesis, mail care, was stirring up a lot of trouble for us, and we walked into a bit of a maelstrom with that, but we got it all sorted out. I think overall the presentation was good. I have just a huge debt of gratitude to Jake, because I blew it. My bad. I forgot to start my screen share when I recorded myself on GoToMeeting. And Jake, God bless him, has spliced in the slides. I've got to take a look at it, but we'll have something up with my voice and the slides, my voice live and the slides, hopefully within a couple of days. We'll also have, I've seen it, but we've got to do some editing, a video of John Teisberg, Professor John, presenting the contraption live, which is a hoot. The contraption got an incredible response. People would just look at it and break down laughing. And I think it was a big hit, and I'm hoping we'll be able to take it back next year. Overall, our reception was great. People loved us. We had about over 40 people come to the reception. I'm really hopeful that some of the pharmaceuticals will give us some money this coming year so that we can pay our moderators and new moderators. And the other news, by the way, not so important for you, is that I think we're about to start a male breast cancer virtual group and a women's breast cancer group in the UK. I still don't have a moderator here. If anybody knows anyone, they can refer them. But we're on the move. So that's it. That's my summary. And if any of you have questions about PCRI and I can answer them, I'd be happy to try to do so.
Rick, I went through the slides and your commentary, and I think you really did an excellent job with it.
Thanks, Dennis. Well, with a bit of luck, you can listen to it one more time, and it'll make a lot more sense because Jake's followed it all along, and he's spliced everything in the right places. But thank you, Dennis.
We hope Jake did that.
Well,
I tried my best.
Oh, I think you did. I have great confidence that you did great, Jake. And even if you didn't, with all that effort, I'd be embarrassed to tell you.
Well, it was fun doing it. I was up till 4 o'clock in the morning, but it was fun.
Thank you.
Rick, where can we find it on the ANCAN website?
It's on presentations and recordings and decks, and you'll see it there, and I think it's at the top under plenary sessions. But as yet, you are going to have to do what Dennis did. You're going to have to download the slides, and you're going to have to listen, and you're going to have to move along and synchronize it yourself. Hopefully, we'll get the synchronized version up on there within a couple of days.
Is this under resources? I see the front page here.
Under resources, isn't there a heading that says recordings and decks?
Oh yeah, recordings and decks. Okay.
So that's where, if you ever want to listen to the recordings of our groups, that's where you find the recordings of our groups. You find the recordings of our plenary sessions, like with Greta McCare or Dr. Moyad, and we've put the recording on there.
And so, which is where is your talk here? Plenary sessions and special topics. Is that what you're talking about?
Right. The bottom one.
Oh, getting the most. Okay, got it. Yeah, yours is the bottom one. Okay. And Dr. Moyad was there apparently, huh?
Dr. Moyad, well, Dr. Moyad is on our site right above me because that was the session we had with Moyad about 3 weeks ago. But Moyad was at PCRI. Yes, he's the master of ceremonies.
Okay. Oh, because it looked like everything under plenary sessions was the PCRI, but it's not. Okay. All right, good. Where do we download the deck? That on the lower right there?
Just read out for everybody what it says after getting the most out the internet.
Open deck first. Click here. Okay. Got it.
Okay.
But as Rick was saying, if you wait a couple of days, you'll be able to hear his voice and see the slides on the screen at the same time. You won't have to manually scroll down or anything.
Oh, okay.
So just give it a day or two.
All right, guys, I'm going to call it a day because I got to get moving. I got to take a quick shower, get changed, and we've got stuff to do. But thank you, everybody. This was a good session. It was a smaller session, and it worked well. And so and we'll be posting this. If you look on that recordings index and you want to listen to anything that you missed again on this session, you'll see it posted at the bottom there within probably 24 hours, maybe less. Okay?
Okay. Thank you.
Thanks, Rick. Have a good evening.
Thank you.
Good night,
Enjoy.
everybody.
Good night.
Okay, good night, everyone.